Welcome to the deep dive. Today, we're really getting into something fundamental for all you future nurses out there: childhood communicable and infectious diseases.
Yeah, it's a huge topic. We're pulling a lot from sources like Wong's Nursing Care of Infants and Children, trying to get you the most practical need-to-know info.
Exactly. We want this to be like a really focused tour, hitting the highlights you'll actually use on the job.
So our mission today, basically give you a clear, solid understanding of these diseases from a nursing standpoint. We'll cover infection control, why immunizations are so key, the details on common illnesses.
Including parasites and fungi, right?
Yep, those two. And nursing care, obviously, plus some emerging stuff. And we've got a special expert later to help break down some of the more complex bits.
Sounds good. Okay, let's jump in. Infection control, this is really ground zero for nurses, isn't it?
Absolutely. It's the bedrock. Standard precautions, that's the starting point.
And these apply to everyone, right?
Yeah.
Every single patient.
Precisely.
Yeah.
Doesn't matter the diagnosis. And it's not just doing them, it's understanding why. Like hand hygiene, knowing when and how is just critical.
And using gloves, other PPE gowns,
Yeah.
masks.
Right. But knowing when to use which piece, it's about assessing that potential exposure risk.
Okay, so that's the baseline. Then we layer on transmission-based precautions if we know or even just suspect something specific is going on.
Exactly. They add to standard precautions.
Yeah.
We've got contact, droplet, and airborne.
Let's start with contact. What triggers those?
Okay, so contact is for germs that spread through touch, either direct, like touching an infected wound, or indirect.
Like touching a contaminated surface. A toy, maybe?
Perfect example. Think RSV, which hits little kids hard, or C. diff.
Ah, C. diff, a common hospital headache.
You got it. And skin stuff like impetigo. So for these, it's gloves and a gown before you even enter the room. And really good hand hygiene when leaving. Sometimes you even need dedicated equipment just for that patient.
Makes sense, breaking that chain of contact. Okay, what about droplet precautions? I'm thinking coughs, sneezes, bigger particles.
Exactly right. These are for infections spread by those larger respiratory droplets. When someone coughs, sneezes, even talks, they don't travel super far, maybe about 3 feet or so.
So things like flu.
Flu, definitely. Pertussis whooping cough, which is nasty, especially in babies and rubella. For these, the key is wearing a mask when you go into the room. It blocks those larger droplets.
Okay. And the last one, airborne. These are the really tricky ones, the tiny particles.
Yeah, these are the infections spread by those really small particles that can just hang in the air for a long time and travel further.
Like measles.
Measles is the classic example, incredibly infectious. Also varicella, chickenpox, and TB, tuberculosis, these need tougher measures.
Like special masks.
Right. Healthcare workers need N95 respirators, and the patient usually needs a negative pressure room.
Ah, so that's the isolation room we hear about.
Often, yes. You keep the air flowing in, but filters it going out, so those airborne germs aren't circulating around the hospital. It's really about containing those tiny floating particles.
Got it. That really clarifies the different layers of protection. So moving from control to prevention, immunizations. This has to be one of the biggest public health wins ever.
Oh, absolutely. It's hands down the most effective way we have to prevent a ton of serious childhood diseases. It's all about prepping the immune system.
And there are two main ways immunity works, right? Active and passive.
Correct. Active immunity is when your own body makes the antibodies. This happens either after you get a vaccine, which introduces a safe version of the germ, or if you actually get sick and recover, your body learns to fight it.
Okay, so the body does the work itself. What's passive then?
Passive immunity is more like borrowing protection. You get antibodies made by someone else. The big example is mom passing antibodies to baby, either through the placenta before birth or in breast milk.
So that gives newborns some early cover.
Exactly. Or sometimes we give injections of immunoglobulins, which are concentrated antibodies. But passive immunity is temporary. It wears off. Active immunity lasts much longer, sometimes lifelong.
Makes sense. So vaccines trigger that active, long-lasting kind, and there's a whole schedule of them for kids. Can you run through some of the key ones nurses deal with?
Sure. The schedule's timed to protect kids when they're most vulnerable. You've got DTaP that covers diphtheria, tetanus, and pertussis.
Whooping cough again.
Yep. Then IPV for polio. MMR protects against measles, mumps, and rubella.
3 big ones in one shot.
Right. Then varicella for chickenpox. Hib for Haemophilus influenza type B used to be a huge cause of meningitis in little kids. Hepatitis A and B vaccines for liver diseases.
What about pneumonia?
PCV, the pneumococcal vaccine, helps prevent serious infections like pneumonia and meningitis caused by pneumococcus bacteria. There's also the rotavirus vaccine for severe diarrhea, and later, for adolescents, the HPV vaccine to prevent cancers caused by human papillomavirus.
Wow, that list really shows how much we can prevent. And the nurse's role here is, well, it's huge, isn't it? More than just giving the shot.
Oh, way more. Nurses are central. Education is massive, explaining the schedule, the benefits, talking through any worries parents have about side effects or safety. You have to build that trust.
And making sure it's safe to give the vaccine in the first place.
Absolutely. Screening for contraindications, reasons why a child shouldn't get a specific vaccine right then administering it safely, right route, right site, good technique.
And watching afterwards?
Yeah, monitoring for reactions. Most are mild, like a sore arm or slight fever. But you have to be ready for rare, serious stuff like anaphylaxis. And finally, documentation is critical, recording everything properly and reporting any significant adverse events to VA-EARS, the Vaccine Adverse Event Reporting System. That's how we track safety nationally.
Okay, let's shift gears and talk about some specific diseases. Understanding the what, why, and how for each is key for nursing care. Let's start with varicella chickenpox.
Okay, varicella. Caused by the varicella zoster virus, super contagious, spread through the air, and by touching the fluid in those itchy blisters.
Ah, the rash. That's the hallmark, right?
Definitely. Usually starts with a bit of fever, feeling unwell, then comes the rash. It goes through stages, little red spots, then fluid-filled vesicles, and they crust over. It's notoriously itchy.
So nursing care is about comfort
Yeah,
and stopping the spread.
pretty much. Isolation is key while they're contagious. Comfort measures like calamine lotion, maybe oatmeal baths to soothe the itching. And for kids at higher risk, like teens or those with weakened immune systems, doctors might prescribe an antiviral like a cyclover to lessen the severity.
Got it. Next, measles or rubeola. We hear more about this one lately.
Yeah, outbreaks happen when vaccination rates dip. It's caused by a virus, also highly contagious, spreads through the air.
What are the key signs nurses should look for?
It usually starts with what we call a prodrome, high fever, cough, corychiza,
Portiza, that's the runny nose, right?
right, runny nose, and conjunctivitis, red, watery eyes. Then you look for Koplik spots,
Koplik spots.
the little white spots inside the mouth on the cheeks. They're a classic early sign. After that, the typical measles rash appears blotchy red, starts on the face, and moves down the body.
And it can get serious.
It can. Complications like pneumonia or encephalitis, which is brain inflammation, are real risks. That's why the MMR vaccine is so vital. Nursing care is supportive, managing fever, watching breathing, keeping them hydrated. Sometimes vitamin A is given too, especially in certain areas, as it can reduce complications.
Okay, mumps. Also in the MMR vaccine, known for the puffy cheeks.
Exactly. The classic sign is parotitis, swelling of the parotid glands near the ears. Can be one side or both. Kids might also have fever, headache, muscle aches.
Is it usually mild?
Often, yes, but complications can happen. Things like orchitis, which is inflammation of the testicles in boys past puberty, or meningitis, even deafness sometimes, though that's rare. Care is supportive pain relief, fluids, isolation.
And rubella, or German measles. Mild for kids, but a big worry for.
Pregnant women, absolutely. In kids, rubella might just be a low fever, a fine pink rash starting on the face, swollen glands behind the ears. Pretty mild stuff usually.
But if a pregnant woman gets it,
Especially early in pregnancy, the risk of congenital rubella syndrome is huge. It can cause devastating birth defects, deafness, blindness, heart problems, developmental delays. It's a major reason we push for MMR vaccination, not just for the individual, but for herd immunity to protect those who are vulnerable, like pregnant women.
wow. Okay, moving to fifth disease, erythema infectiosum. That's the slap cheek one.
Yep, caused by parvovirus B19. That bright red rash on the cheeks is very distinctive. They might also get a lacy-looking rash on their body, maybe mild fever or joint pain.
Is it generally okay for kids?
Usually, yes.
Yeah.
It's typically mild and goes away on its own. The main concern, again, is for pregnant women. Infection during pregnancy can lead to serious problems for the fetus, even fetal death. So, pregnant women should avoid contact if there's an outbreak. Nursing care is just about comfort.
Okay, roseola, another common one in little kids. Often presents with that fever first, then the rash.
That's the classic pattern. Roseola usually starts with a really high fever, like 102 to 105 degrees, for a few days. Then, boom, the fever breaks, and this pink, non-itchy rash appears, often starting on the trunk.
And it's mostly infants and toddlers.
Yeah, typically kids between 6 months and 2 years old. Sometimes the high fever can trigger a febrile seizure, which can be scary for parents. Nursing care is mainly about managing that fever with acetaminophen or ibuprofen and reassuring parents about the rash that comes after.
Let's talk pertussis whooping cough. That sound is unforgettable.
It really is. Caused by the bacteria Bordetella pertussis. The hallmark is those severe coughing fits, just one cough after another, and then that high-pitched whoop sound when they finally gasp for air.
Sounds awful.
It is, especially for babies. They might not even, they might just stop breathing, have apnea spells. Prevention with the DTaP vaccine is so important.
Is there treatment?
Yes. Antibiotics are key to kill the bacteria and make the person less contagious. Drugs like azithromycin, clarithromycin, or erythromycin are commonly used. Nursing care is intense, watching their breathing very closely, maybe giving oxygen, keeping them hydrated, and trying to keep things calm to avoid triggering more coughing.
Okay, last one in this group. Scarlet fever, linked to strep throat.
Exactly. It's caused by the same group A strep bacteria. So you get the sore throat, the fever, but then you also get specific signs like a strawberry tongue, looks white at first and turns red and bumpy.
And the rash.
A very characteristic sandpaper-like rash. Feels rough. Usually starts on the neck and chest and spreads. Because it's bacterial, antibiotics are crucial, usually penicillin or amoxicillin or maybe erythromycin if there's a penicillin allergy. This treats the infection and prevents serious complications like rheumatic fever. Nursing involves monitoring, comfort for the sore throat and fever, and stressing how important it is to finish all the antibiotics.
Phew, that's a lot of bacteria and viruses. But we also need to think about parasites and fungi, right?
We do. They cause their fair share of childhood issues. Let's start with giardiasis.
Okay, Giardia, what's the rundown?
Caused by a tiny parasite, Giardia lamblia. It's mainly a gut thing, diarrhea, often greasy, plus gas, bloating, cramps.
How do kids get it?
Fecal-oral route. Contaminated water is a big one, but also person to person, which is why you see it spread easily in daycare centers. Good hand washing is key. Treatment involves antiparasitic meds like metronidazole or nitazoxanide.
Okay, and then pinworms, anaerobiasis, sounds unpleasant.
Yeah, it's common though. The main symptom is intense itching around the anus, especially at night. It really disrupts sleep.
Why the itching?
The female worms actually crawl out at night to lay their eggs on the skin there. Diagnosis often uses the tape test, stick clear tape to the area first thing in the morning before bathing, then look for eggs under a microscope.
And treatment.
Meds like albendazole or mebendazole, and usually the whole family needs treatment because it spreads so easily. Again, meticulous hand washing is vital.
All right. Lastly, candidiasis. Yeast infections, basically.
Right. Caused by the fungus Candida albicans. We often see it in two main ways in kids: oral thrush, white patches inside the mouth, on the tongue and cheeks.
And the other?
Diaper rash. A really bright red, sometimes raised rash in the diaper area. Often happens if the area stays moist or after antibiotics.
How do we treat these?
For thrush, usually an oral antifungal liquid like nystatin suspension. For the diaper rash, a topical antifungal cream, often nystatin cream too. Keeping the diaper area clean and dry helps prevent the rash.
Okay, we've covered a ton of ground. Some of the underlying mechanisms, the pathophysiology, can get a bit complex. So let's bring in our expert to clarify a potentially tricky point for our future nurses. Welcome.
Happy to be here.
Great to have you. So we've been discussing all these diseases, their symptoms, treatments. One thing that might be confusing is how different infections cause similar symptoms, like rashes. We talked about the measles rash, which is viral, and the scarlet fever rash, which is bacterial toxin related. Could you maybe elaborate a bit on the basic difference in how those rashes actually develop? And maybe also why antibiotics like azithromycin work for pertussis but are useless against something like chickenpox?
Absolutely. Great questions. They get to the heart of understanding why we treat things differently. Let's take the rashes first. Measles rash, that's largely the virus itself, infecting cells in the tiny blood vessels of the skin. Your immune system, specifically T cells, then attacks those infected cells. This battle, this inflammation at the cellular level, is what you see as the blotchy rash. It's a direct result of the virus being in the skin and the immune response to it.
Okay, so virus directly involved in the skin.
Exactly. Now, scarlet fever is different. The strep bacteria are usually just hanging out in the throat. They produce toxins, erythogenic toxins. These toxins get into the bloodstream and circulate throughout the body. The rash is actually a hypersensitivity reaction to these toxins elsewhere in the body, specifically in the skin. It's not the bacteria themselves in the skin causing the rash, it's the body reacting to the toxins they released. So viral rash, direct infection, and immune response in the skin. Scarlet fever rash equals systemic reaction to bacterial toxins.
That makes so much more sense. One's local war, the other's like a reaction to distant artillery fire.
Kind of, yeah.
Yeah.
Now, antibiotics versus antivirals. Antibiotics like penicillin or azithromycin target structures or processes that are unique to bacteria and essential for their survival. Penicillin messes up their ability to build cell walls. Human cells don't have walls, so we're generally okay. Azithromycin gums up their ribosomes, the machinery bacteria use to make proteins. Again, bacterial ribosomes are different enough from ours that the drug mainly hits them.
Okay, so they exploit differences between bacteria and human cells.
Precisely. Viruses are different beasts altogether. They don't have cell walls or their own ribosomes. They're basically hijackers. They invade our cells and use our cellular machinery to make more copies of themselves. So antibiotics that target bacterial structures just won't work.
Because viruses aren't using those structures.
Right. Antivirals, like a cyclover for chickenpox, have to be much more targeted. They interfere with specific steps in the viral replication process. A cyclover, for instance, messes with the virus's ability to copy its DNA, a step critical for making new viruses. But it does so in a way that's relatively specific to the virus-infected cells. So, antibiotics target bacteria-specific things. Antivirals target virus-specific things.
That is incredibly helpful. Seeing the why behind the drug choices really clarifies things. Thank you so much for breaking that down.
My pleasure.
Okay, let's bring this back to the bedside. For our nursing students listening, what are the absolute core elements of managing care for kids with these infections?
Well, it really starts with sharp assessment skills. You need to evaluate the symptoms, understand how the illness is progressing, and get a good history, any known exposures. Then come the interventions. Hydration and nutrition are huge, especially with fever or tummy troubles.
Keeping those fluids up.
Definitely. And promoting rest. Managing symptoms is key, using acetaminophen or ibuprofen correctly for fever, finding ways to soothe itching or coughs.
And of course, stopping the spread.
Paramount. Using the right isolation precautions, contact, droplet, airborne religiously, and hand hygiene, hand hygiene, hand hygiene. You can't say it enough. Plus, using PPE correctly.
Gowns, gloves, masks, and 95s when needed.
Exactly. And it's not just us doing it, it's teaching the family too, explaining why these precautions are needed. And let's not forget emotional support. Being sick and isolated is scary for kids and stressful for parents. Offering reassurance, explaining things in kid-friendly ways, just being present, that's vital nursing care too.
And that education piece for parents goes beyond just hand washing, right? What else do they need to know?
Oh yeah, it's crucial. We need to teach them about the illness itself, what to expect, what are the warning signs that things might be getting worse.
Like when to call the doctor or go back to the ER.
Exactly. Clear instructions on that. Also practical things like how to manage fever or other symptoms at home. And explaining when the child is no longer contagious and can safely go back to school or daycare that helps prevent community spread.
And medication instructions too?
Absolutely. Making sure they understand the dosage, how often to give it, why it's important to finish the entire course of antibiotics, for example. Answering their questions, addressing their worries, that empowers them to be partners in their child's care.
Looking towards the future now, what are some key challenges or emerging issues in pediatric infectious diseases that nurses should have on their radar?
Well, antibiotic resistance is a huge ongoing concern. Bacteria are getting smarter, tougher to treat. That makes antibiotic stewardship, using antibiotics wisely, absolutely critical for everyone in healthcare.
So not demanding antibiotics for every little sniffle.
Precisely. We also still see outbreaks of vaccine-preventable diseases, unfortunately.
Yeah.
So continuing education and communication about vaccine safety and importance remains vital. Then there are always new threats, think Zika a few years back, or novel flu strains. We need good surveillance and rapid response.
And infections picked up in the hospital?
Yes, hospital-acquired infections like MRSA or C. diff are a constant battle. It just reinforces the need for strict infection control practices all the time. And, with global travel, diseases can spread faster than ever, so having that broader awareness is important too.
This has been such a valuable deep dive. We've really covered the spectrum from basic infection control and the power of vaccines through the nitty-gritty of common viruses, bacteria, parasites, fungi, including key nursing actions and treatments.
Right up to thinking about those bigger picture emerging concerns.
It's all knowledge that's absolutely foundational for you as you start your nursing careers. You really are on the front lines preventing, identifying, caring, and educating when it comes to protecting kids.
And remember, this field is always changing, so keep learning. Keep asking questions. Think about how these principles apply in real situations you encounter. Consider the connections between individual patient care and broader public health. What questions linger for you after this discussion? What sparks your interest to learn more? Keep that curiosity alive. It's what will make you a truly excellent nurse, ready to tackle whatever comes next in pediatric infectious diseases.